And we will move on the next excellent speaker, another doctor, researcher, and professor Aris Liakos from Hippocratio. He will talk to us for the effect of GLP-1 arrays on blood pressure. Dear Aris.
Thank you, Dr. Skoutas, for the nice introduction, and I'm very grateful to the organizing committee for this opportunity to share with you the most up-to-date evidence about one of the many and often relatively neglected effects of GLP-1 receptor agonists, which is their effect on blood pressure. And to begin with, during the next few minutes, I will try to summarize the available evidence from randomized controlled trials and systematic reviews thereof about blood pressure control with GLP-1 receptor agonists and the potential underlying mechanisms, focusing on findings from dedicated blood pressure trials. I will also discuss what the future might bring in this field. Thomas already said a few nice things about that, with the clinical development of novel agents such as the multi-agonist peptides that were already mentioned and oral formulations of GLP-1 receptor agonists. Just to remind you that the first GLP-1 receptor agonist exenatide was approved back in 2007, more than 20 years ago, and several agents have been introduced ever since, mainly for the management of diabetes, although their indications have recently expanded to include obesity and cardiorenal risk reduction. So diabetes and hypertension are obviously part of the metabolic syndrome phenotype, and the presence of both conditions confers excess risk for cardiovascular and microvascular complications. In fact, management of hypertension in type 2 diabetes has been associated with a 12% reduction of all-cause mortality, lower rates of myocardial infarction by 12%, and lower incidence of stroke by 19% for every 10 millimeter mercury decrease in mean systolic blood pressure. But despite the availability of multiple drug classes for hypertension, blood pressure targets are still rarely reached in as few as 50% of patients with diabetes, for whom polypharmacy is obviously another big issue. And let me start by discussing the available evidence regarding the effect of GLP-1 receptor agonists on blood pressure. These are findings from a network meta-analysis conducted a few years ago from our group regarding the effect of all available glucose-lowering medications on body weight and blood pressure. This was a heroic effort for searching the literature and extracting necessary information, which resulted in 200 randomized controlled trials with more than 150,000 participants. So, beyond the SGLT2 inhibitors, which is admittedly the most efficacious anti-diabetic drug class for reducing systolic blood pressure, you can see that several GLP-1 receptor agonists, including semaglutide, exenatide, liraglutide, and dulaglutide, conferred reductions in the order of magnitude of 2 to 3 millimeters mercury. With respect to intra-class differences between individual GLP-1 receptor agonists, you can also note that semaglutide was more efficacious than dulaglutide and lixisenatide. The level of confidence in the effect estimates was generally moderate, as indicated by the blue color in the graph. Regarding diastolic blood pressure, SGLT2 inhibitors were again the most efficacious agents. In this analysis, only the GLP-1 receptor agonist exenatide once weekly was associated with marginal reductions in diastolic blood pressure, whilst dulaglutide was inferior to exenatide twice daily and semaglutide. A high level of confidence in the effect estimates was generally noted, as indicated by the green color in the graph. And notably, GLP-1 receptor agonists, and particularly subcutaneous semaglutide, by far are the most efficacious agents for reducing body weight, based on high to moderate certainty evidence, as indicated by the green and blue color respectively. So it still remains controversial, though, whether the blood pressure reduction with GLP-1 receptor agonists is only accounted for by weight loss. A few years ago, we also conducted a multi-centered placebo-controlled trial across 7 study sites in Greece, which aimed at ascertaining the ambulatory blood pressure profile of liraglutide in hypertensive patients with type 2 diabetes. The duration of the trial was 5 weeks and 62 patients were enrolled in total. As you may note, based on ambulatory blood pressure monitoring, liraglutide reduced systolic blood pressure by 5.73 millimeters mercury compared with placebo, and this result was mainly driven by daytime measurements. Change in mean 24-hour systolic blood pressure did not differ between liraglutide and placebo arms, and this finding was consistent in both daytime and nighttime measurements. And finally, we noted an increase in 24-hour heart rate of 6.16 beats per minute relative to placebo, and this chronotropic effect of liraglutide was sustained throughout the day. Let me open up a parenthesis at this point. Can this chronotropic action lead to an increased incidence of tachyarrhythmias? Based on data derived from 8 major cardiovascular outcome trials for GLP-1 receptor agonists with over 60,000 randomized participants, no significant effect was seen on total arrhythmias and its subtypes, including atrial fibrillation, atrial flutter, ventricular arrhythmias, or sudden cardiac death. Now, on to another dedicated placebo-controlled trial that utilized 24-hour ambulatory blood pressure monitoring for dulaglutide, 1.5 milligrams per week, which resulted in a 2 to 3 millimeters mercury reduction in systolic blood pressure and a 3 to 4 beats per minute increase in heart rate throughout the 26-week treatment period. Nevertheless, the placebo-subtracted differences did not reach statistical significance for superiority, and the blood pressure lowering in systolic blood pressure was evident already after 4 weeks of treatment. Thomas already mentioned tirzepatide, which is the newly approved once-weekly dual GIP-GLP-1 receptor agonist, approved for the management of obesity and diabetes. The drug demonstrated clinically significant improvements in systolic blood pressure ranging from 4 to 13 millimeters mercury reduction in systolic blood pressure across the 3 doses, 5, 10, and 15 milligrams at 40 weeks of treatment in the SURPASS clinical development program. Unlike meta-analysis relying on office-based blood pressure measurements, we also have similar evidence synthesis of trials with GLP-1 receptor agonists utilizing 24-hour ambulatory blood pressure monitoring, which have so far provided mixed results. Nevertheless, the landscape might start to change with an introduction of newer GLP-1 receptor agonists. And the question is, what are the underlying mechanisms behind the positive effect of GLP-1 receptor agonists, mainly on systolic blood pressure? In this work, Katut and colleagues pulled together results from all published studies reporting on the effect of GLP-1 arrays on blood pressure. The investigators used a meta-regression approach in an attempt to understand the relationship between blood pressure lowering and improvements in weight and glycemia. They concluded that GLP-1 receptor agonists induce a small but significant change in systolic blood pressure that appear to be independent of baseline characteristics known to influence blood pressure, such as weight loss, thereby adding to a growing body of evidence suggesting that GLP-1 agonists may have weight-independent cardiovascular effects that may lead to this favorable modulation of cardiovascular events. Nevertheless, the main limitation of this analysis, which was conducted several years ago, was that only trials with exenatide and liraglutide were included back in that time. GLP-1 receptor agonists, let me remind you, that are now used for the management of overweight and obesity, irrespective of the presence of type 2 diabetes. So this recently published meta-analysis in 2024 reveals that the blood pressure lowering effects of semaglutide are retained regardless of the presence of background type 2 diabetes. Animal and mechanistic studies have offered interesting insights into the effect of GLP-1 receptor agonists on blood pressure. Several mechanisms have been proposed. Increased natriuresis either through augmented atrial natriuretic peptide levels or through decreased sodium reabsorption in the proximal convoluted tubule, lower sympathetic nervous activity or decreased vascular resistance via endothelial nitric oxide release, and finally lower levels of angiotensin II have all been proposed as potential explanations behind the blood pressure lowering effects of GLP-1 receptor agonists. In our trial conducted some years ago, apart from the ambulatory blood pressure and heart rate measurements, we also had incorporated a mechanistic study to explore the effects of liraglutide on renal sodium handling. GLP-1 receptors are reportedly expressed in porcine proximal tubular kidney cells at the mRNA level. And because lithium ions are absorbed in parallel with sodium in the proximal convoluted tubule, we used lithium excretion to gather information about proximal tubular sodium handling. What we found out is that natriuresis did not differ between participants in the liraglutide and those in the placebo group, and this was also the case with urine lithium excretion, although other trials have suggested an increased sodium excretion after short-term treatment with liraglutide, but we were not able to replicate these findings. These are the findings of a mediation analysis which was conducted across the sustained clinical development program of semaglutide. A mediation model, some of you may not be familiar with that, seeks to identify and explain the mechanism that underlies an observed relationship between an independent and a dependent variable via the inclusion of a third hypothetical variable, which is known as the mediator. So with semaglutide, obviously greater weight loss was generally associated with greater reductions in systolic blood pressure. However, for those subjects who did not experience changes in body weight, systolic blood pressure reduction up to 5 millimeters mercury was still evident after treatment with 1 milligram of semaglutide relative to comparators, thus suggesting that the blood pressure lowering effect might be driven by weight-independent mechanisms as well. Another interesting phenomenon is the postprandial hypotension. Postprandial changes in blood pressure are yet incompletely understood. Postprandial hypotension is currently defined as a fall in systolic blood pressure of at least 20 millimeters mercury within 2 hours of the start of the meal, or a fall or a systolic blood pressure less than 90 millimeters mercury when baseline systolic blood pressure levels are above 100 millimeters mercury. So the phenomenon of postprandial hypotension affects approximately 25 to 40% of people with diabetes, and has been shown in a number of epidemiological studies to be a major contributor to morbidity and mortality, predisposing to syncope, falls, coronary events, and stroke. In health, meal ingestion is associated with an approximate doubling of intestinal blood flow, which in turn leads to a substantial increase in heart rate to maintain blood pressure. Accordingly, a fall in blood pressure is indicative of inadequate cardiovascular compensation. The pharmacologic slowing of gastric emptying, such as after treatment with GLP-1 receptor agonists, might attenuate this fall in systolic blood pressure. Indeed, intravenous infusion of the short-acting GLP-1 receptor agonist exenatide was shown to attenuate the fall in blood pressure induced by a mixed meal, and this reduction in postprandial hypotension might be relevant to the beneficial cardiovascular effects of this drug class. And what does the picture look like regarding the effect of GLP-1 receptor agonists on blood pressure with the advent of newer agents, which, as already Dr. Karagiannis said, seem more potent with respect to weight loss and glycemic management? So, looking at the next generation of treatments for obesity and diabetes, GLP-1 receptor agonists will likely become the backbone therapy in combination with other enteropancreatic hormones which have complementary actions and synergistic potential, such as the GAP, the glucagon agonists, or the amylin mimetics, such as cagrilintide. Let's have a look at the results for tirzepatide, which is the first approved GAP-GLP-1 receptor agonist for the management of diabetes and obesity. These are the findings from a dedicated 24-hour ambulatory blood pressure trial. As you can see, all tirzepatide doses were associated with significant reductions in systolic blood pressure at 36 weeks compared with placebo. Participants who received tirzepatide 5 and 10 milligram, but not 15 milligram, had also significantly reduced 24-hour diastolic blood pressure relative to placebo after 36 weeks of treatment. And again, an increase in 24-hour heart rate was observed with all tirzepatide doses relative to placebo. This seems to be a consistent drug class effect. So, weight loss of approximately 5 to 10% is expected to improve systolic blood pressure. We know that for sure by at least 5 millimeters mercury. In pooled analysis of the whole SURPASS clinical development program, weight loss associated with tirzepatide explained the majority of treatment effect on systolic blood pressure. Nevertheless, the correlation between weight loss and blood pressure reduction was relatively weak, an observation that further raises the curiosity to explore potential weight-independent mechanisms that could be driving this reduction in systolic blood pressure. Let me also note that reductions in systolic blood pressure with tirzepatide were not dependent on concomitant antihypertensive medications at baseline, as similar reductions were observed whether participants were receiving them or not, and the largest systolic blood pressure reductions were observed in the highest baseline pressure category as compared with the first quartile of the baseline SBP category, in which patients did not observe further decreases in systolic blood pressure. Finally, tirzepatide seems to be superior than semaglutide in reducing systolic blood pressure, which could be attributed to greater weight loss, or it could also be partly explained by the GAP-specific mechanisms that warrant further investigation. What about triple agonism? Retatrutide is a novel GAP, GLP-1, and glucagon receptor multi-agonist. Initial findings from a phase 2 trial suggest an impressive body weight reduction up to 24% after 48 weeks of treatment, which is comparable to weight loss achieved with metabolic surgery. And we have very interesting findings by the very same trial. As you can see, semaglutide 8 milligram was associated with approximately 12 millimeters mercury reduction in systolic blood pressure based on data derived from 24-hour ambulatory blood pressure monitoring, and diastolic blood pressure was also reduced by 3.5 millimeters mercury. What is also quite interesting to note is that 41% of the participants in the combined 8 milligram retatrutide group and 30% of the participants in the 12 milligram group were able to discontinue at least one antihypertensive medication. Given the currently available options for weight management, there is still an unmet need for an oral incretin-based therapy with efficacy that could be similar to that of injectable agents. Such therapy has the potential to increase acceptance of treatment, persistence of use, and adherence and treatment adherence. So orforglipron is a once-daily oral non-peptide GLP-1 receptor agonist that is currently in development for the management of type 2 diabetes and obesity. Body weight loss of approximately 15% was noted with orforglipron in this early phase 2 trial that enrolled people with overweight or obesity, but without diabetes. And here, the mean reduction from baseline in office-based systolic blood pressure was up to 10.1 millimeters mercury at week 36 with orforglipron, as compared with 1.8 millimeters mercury with placebo. The systolic blood pressure tended to be lower in all orforglipron dose cohorts than in the placebo arm during the trial. Nevertheless, there was no clinically meaningful change in the systolic blood pressure among participants who received orforglipron, and again, an increase in pulse rate ranging from 3.2 to 7.4 beats per minute was noted across the orforglipron dose cohorts. Findings for blood pressure reduction with orforglipron were also encouraging in this trial, which included individuals with diabetes and was published in The Lancet in 2023. And another question is, what about combination treatment? So amongst glucose-lowering agents with cardiorenal benefits, the SGLT2 inhibitors class is admittedly the most effective in reducing blood pressure. GLP-1 receptor agonism leads to a loss of body weight, which has a downstream effect on systolic blood pressure and subsequently improves cardiovascular outcomes. On the other hand, SGLT2 inhibitors induce osmotic diuresis and urinary sodium excretion, thereby contributing to a reduction not only in hemoglobin A1C levels, but also in systolic blood pressure. So the question is whether the combined actions of body weight loss and reduction in hemoglobin A1C levels associated with both drug classes may have the potential to further decrease systolic and to a lesser extent diastolic blood pressure, culminating in beneficial effects, even more beneficial effects on cardiovascular outcomes. So to sum up, I think it has become evident that most GLP-1 receptor agonists induce modest reductions in systolic and to a lesser extent in diastolic blood pressure. Regarding differences between individual agents, the dual GLP-1 receptor agonist tirzepatide seems more effective. Maybe if approved, the triple agonist may be even more effective than that. And tirzepatide is more effective than semaglutide, which in turn is more effective than liraglutide and exenatide, whereas available data for dulaglutide and lixisenatide do not fully support a favorable effect on blood pressure. Nevertheless, this ranking should be taken with caution, obviously, due to the lack of direct comparisons. These blood pressure lowering effects of GLP-1 arrays are probably incompletely accounted for by weight loss, especially for first-generation GLP-1 receptor agonists, which are less effective in reducing body weight. And this is why several mechanistic studies, as I have already shown you, have tried to elucidate other mechanisms that might be implicated as well, but to no avail yet. Similarly, we are confident about the positive cardiovascular profile of these agents based on overall findings from cardiovascular outcome trials, but we cannot yet fully explain the intra-class differences. For instance, we do not adequately understand, for example, why the reduction with systolic blood pressure is greater with SGLT2 inhibitors than with GLP-1 arrays, but the risk of stroke at the same time was lower with GLP-1 receptor agonists. On the other hand, these benefits come with an increase in heart rate, which has been consistently observed in all trials of GLP-1 receptor agonists, although no increased incidence of tachyarrhythmias has been identified. Maybe this positive chronotropic effect could provide a hint as to why GLP-1 receptor agonists have not been yet extensively used in heart failure patients as opposed to SGLT2 inhibitors. I have to say that the future in this field seems quite bright with the advent of GAP, GLP-1, and glucagon receptor triple agonism, which could yield impressive pharmacologic body weight reduction that can only be compared to bariatric surgery. Thank you very much.